Dr. S. Ambika. She's going to talk on the localizing the lesions made simple. Lesions using the eye, localizing lesions anywhere in the body can be made simple. Your eyes and patient's eye, both. Thank you. Start now.
Good afternoon. So my talk is on localizing lesions. And we all know that in neuro-ophthalmology, there are two main complaints which do present to us: vision loss and diplopia. With this 15 minutes, I will try to do with the first one, and I doubt whether I could move on to the second. So we all know about this conventional drawing which we have come across in our med school, where we have this different types of field loss, which is probably going to localize the lesion. Instead of going like this, because we have seen it quite frequently, I'm going to do it on case-based approach. So any detailed history of a vision loss is going to help us where the lesion is associated with the other symptomatology what the patient presents with. So let me take a vision loss. So the vision loss can happen in any part of this entire visual pathway. So I have grouped it into an optic nerve and an immediate retrobulbar nerve, and the posterior optic nerve with the chiasm, and the tract and the radiations, and that of the occipital cortex. So we have grouped it into 4 type of diseases, and this is what is the entire list of causes which can cause these type of lesions anywhere in the visual pathway. And remember that at the level of LGB we lose the pupillary pathway, so any lesion which is higher above the pupillary pathway which is causing the dysfunction is going to show you a normal pupillary reaction. So all the optic nerve dysfunction test has to be performed in any patient with vision loss, starting from vision, color vision, to pupillary examination, fundus appearance, and the visual fields and the structural parameters. So let me go with case, and if there are postgraduates, you can join in and discuss. So this is a 30-year-old female who came with a sudden drop in vision in the left eye with a 6 days duration, and the vision in the left eye was counting fingers 2 meter, and she carried a visual field with her which she tried performing in the beginning, which had an advanced loss in the left eye, and the right eye was normal, and the color vision was normal in the right, but the left was impaired. So where do you think the lesion is? So this is the fundus appearance. So you see a disc edema in the left eye. So it is not only what we see in the fundus that is showing the lesion, but the next thing is the MRI. And what you see here is an coronal MRI with a post-contrast enhancement of the left optic nerve. The inflammation is not only settling with the level of the fundus, it's also behind the optic nerve. What you see here is a diffuse enhancement and a thickening of the optic nerve along with the sheath, periorbital sheath stranding, and a fat which is being bright. So you don't see generally this type of changes in an optic neuritis. And if you see something like this, remember there is a group of optic neuritis which are atypical. So this is a group of atypical optic neuritis where it turned out to be MOG, and the patient was a MOG antibody positive atypical optic neuritis, and post steroids they did better. So this is a 37-year-old female, again with a monocular presentation of one eye vision loss, but she gave a history of low-grade fever 3 weeks back and a headache. If you could see, the right eye is dropped in visual function and that of the left eye is preserved. She had a moderate drop, which is 618 N8, and she gave a brilliant history of TB in her brother with whom she is living. So when you get such history living in India, do not forget that we do also have an infective overlay of all the optic neuritis. So this is the fundus of that eye, which had a drop in vision, a significant disc edema, which was seen on the SSOCT2, and a dense inferior altitudinal loss. And that of the left eye was normal. So here, the lesion is again in the optic nerve, but if you see the location, it's not only in the diffuse optic nerve, it's more in the sheath. You could see that there is a bright enhancement of the sheath alone, which can be picked up over here. So that is more of a perineuritis-like picture. That's an optic nerve sheath enhancement, what you see in this patient. So here the location is different, but the patient is again manifesting with the same presentation. And her systemic evaluation showed that, yes, she was also positive for TB, had an hilar adenopathy. So subsequently, we put her, along with steroids, a course of antituberculous therapy. And this is a visual field, and vision improved by 4 weeks. So this is a 47-year-old female who came with a history of painful diplopia, which was in the past, which improved with steroids. And she also had a sudden drop in vision in both eyes, left eye more than the right eye. which was painful diplopia, redness, and grossly restricted extraocular motility, and her vision was normal. And when you could see this, you can see that how much of engorgement, thickening, chemosis, redness, everything, say name it, you have all soft tissue signs, and her extraocular motility is grossly restricted in all directions. She did not have any history of trauma, so there was no bruit, there was no thyroid abnormalities. So this is the fundus. Again, we are seeing a bilateral disc edema. So where do you think the lesion is? The fields was having a very subtle central depression in both eyes. And this is what you see in the MRI. Here, it's not the nerve which you are seeing, it's more of the muscles. You can see the diffuse brightening up of the extraocular muscles, which is crowding at the orbital apex. And this is a type of thickening which is also extending to the tendons, which is not like a thyroid. So you see a diffuse engorgement of the EOM, soft tissues and everything causing an orbital compression. And here you can see the gross thickening of the extraocular muscle. So our provisional diagnosis was either a myositis or an IOID. And as a convention, we also get all the inflammatory markers. So post IV steroids, she did improve, but we went ahead and performed a muscle biopsy which showed a chronic granulomatous inflammatory infiltration with a significant granulomas in that was a sarcoid myositis. So here the disc edema was due to the extraocular muscle inflammation. So this is the post-treatment outcome of that patient post IV and oral steroids. So coming to the chiasm, any unexplained vision loss, headache, color vision difficulty in depth perception, and bitemporal field loss, you have to suspect a chiasmal syndrome. And there can be also a raised ICP, which is not that commonly seen in a chiasmal syndrome, but yet is it possible. When the lesion in the chiasm is going suprasellar, it starts compressing the third ventricle and you will end up seeing a disc edema. And you can also see sometimes endocrine features like acromegaly and gigantism. So this is a chiasmal syndrome disc. You can either see a temporal pallor or you can see a bow-tie pallor, which is not that commonly seen. In chronic chiasmal compression, you would end up seeing a bow-tie pallor. And as I said, you can also get a ophthalmoplegia sometimes when the lesion is going parasellar, because we all know that in the lateral wall of the sinuses, we have all the cranial nerves sitting over there, and any mass which is involving the paracella is going to result in vision loss as well as in a cranial nerve palsy. So this is one example where this guy was diagnosed elsewhere as a traumatic optic neuropathy. You could see the gross disparity on his face. You could see a gross enough, a displaced globe, a periorbital fractures, and he said that he has left eye vision drop for 4 years. And he said that left eye vision is worsening day by day. Well, that history doesn't go with a traumatic optic neuropathy. So this is the disc what you see. Definitely this is not a left eye optic disc which is having a 4 years onset of traumatic neuropathy. It's still pink. So this is the field of the left eye and that of the right. So where do you think the lesion could be? Fine. So the patient had only a CT orbit which had multiple fractures. So we went ahead an MRI and it showed a suprasellar lesion which is compressing the nerve as well as the chiasm, and that was the reason for his left eye vision. So don't go about just with the history where the patient had a trauma, had so much of deformity in the face, CT showing a lot of orbital fractures, but yet that was not the reason for the vision loss what he had, and that's the chiasmal lesion. And this is the post-treatment, post-neurosurgical excision. The patient had a very good visual recovery. Co-chair, you can stop me at the time when I'm shooting up. So this is case 5, which is a 41-year-old female who came with history of ptosis and squint for 2 years duration, and she was diagnosed elsewhere as thyroid eye disease, and she had a vision loss in the right eye also. What you see here, she has a squint. What you see here, there is a restricted adduction and there is a restricted elevation, and there is a very mild ptosis in the primary gaze, and you see the lid is not following the globe in the right eye. So what is that sign called? That's the inverse Duane's with a pseudo-1 graphe, and she had a right third nerve with a chronic compression. She has developed an aberrant regeneration. So that's a right third, fourth, and an optic nerve. Definitely the level of lesion is at the chiasm, which was seen in this visual fields, having a dense temporal loss in one eye, and that of the left eye showing a superotemporal loss. So this is the lesion what I told, the cellar which is spilling over into the right paracellar area, and that's the cause. See, this is a classical dumbbell type of appearance. Cellar, supracellar and paracellar, the mass was extending. So post-treatment, the patient had a good recovery of the vision as well as the ocular motility. Coming to the retrochiasmal lesions, hemianopia, if you look into, you have to look into the congruity of the hemianopia, because any complete isolated homonymous hemianopia is non-localizing. Incongruous hemianopia will localize. The more anterior the lesion is, you will get an incongruous lesion, and the more posterior the lesion is, you will get a congruous lesion. So this is a complete left homonymous hemianopia, and this is an incongruous left homonymous hemianopia. So coming to the cause, you could read up in the textbooks, which is mostly vascular followed by trauma. So this is a 51-year-old male who was brought by the wife saying he's frequently falling for the past a week or so. So when we saw, he had a 6/6 vision, and anterior and posterior segment evaluation was normal, but this is the fields. What is the type of fields you see here? It's a right inferior quadrant anopic defect, what we call as a pie in the floor field. And when we imaged this patient, he had a significant left subacute bleed with the SOL and a surrounding cerebral edema. That man is lucky to have come this time because he didn't go in for a midline shift and pop off. So that patient was a only field loss showing up with a massive lesion in the brain. And this is again a 59-year-old male who had a sudden drop in vision in the left eye post CABG, and surprisingly after pandemic or while pandemic, everything was related to COVID. So post-COVID optic neuritis was the diagnosis what this patient came to us with. So his vision was better, but he said that his field did not recover after the steroid treatment. And when we saw the fundus, it was like this. And this field is definitely not only an optic nerve type of field loss. So this is a significant left optic, left side hemianopia. And this was his MRI, which showed a massive right PCA, MCA area subacute infarct. So this is the lesion which is causing that field loss and the disturbance for him. So this is a case which is a 65-year-old male who was brought to us for cataract surgery by his kid. And he said that from suddenly off late, he is not having a good vision. He is bumping into objects. We have brought him for a cataract. Well, that history is not something good, because the patient was having a PL vision which was not correlating, although he had a near total dense cataracts in both eyes. And he had a normal fundus examination and anterior segment. And subsequent VEP also showed a relatively good waveforms, but with a delayed latency. Still not able to explain the vision, we went ahead and MRI. So the MRI showed a right side subacute lesion with a left side chronic involvement, and that was a cortical visual impairment. So with this, I wind up with the vision loss, and probably I will move on to the conclusion slide. So detailed history taking is the key for an onset of symptoms and localization. Always associate other complaints like headache, pain, and the type of the field loss, which will help you in making the lesion localization, and correlate the vision loss to the clinical features, and differentiate retinal and other causes from optic neuropathy, and do ask for a contrast enhanced MRI brain and orbit, because there is very limited role of CT brain and orbit in neuro-ophthalmology. Thank you so much.
Thank you, Dr.